We are live, sir. Control sir.
Hmm? Just
You
a
can
minute.
start.
Hello. I think he's driving. अगर देख लो, अगर ज्वाइन कर सको तो 2 मिनट के लिए. हम्म. हाँ. डॉक्टर ललित स्टार्टेड. डॉक्टर अजय आ गए हैं, वो अपना ज्वाइन. हाँ, जरा उनको बोल देना. शी विल स्टार्ट. यस प्लीज.
Good afternoon, everyone. On behalf of IAP Delhi, I welcome you all for joining us today's CAB on urinary tract infection.
जब तुम भी बिजी हो गए,
As you all,
हम डीएम में गए हो गया, तुम डीएम में लग गए. नहीं, सारे मेंबर्स की लिस्ट तुमने मुझे एक्सेल शीट पे देनी थी ना, भूल गए.
डॉक्टर अजय, योर माइक इज ऑन.
तो मैंने तुम्हें तब से तो मांगी है, तुमने कहा कि अभी मैं कर रहा हूँ.
moderator,
आपका माइक ऑन है, पीछे से बैकग्राउंड वॉइस आ रही है.
मेरी आवाज आ रही है?
या वी कैन हियर यू.
हाँ, ये गो अहेड.
Okay, sir. And our esteemed senior moderator, Dr. Vasudev, sir, renowned nephrologist, whose vast experience in renal and urinary disorder will enrich today's discussion, more focused and interactive. And hope this session will be interactive for all of us. Now I welcome Dr. Ajay Kumar Gupta, sir, who is present to say a few words.
Thank you, Dr. Lalit. I congratulate IAP Delhi branch for doing such a nice academic work. And keep up this work. This will be very useful for all practicing pediatricians as well as residents. So wish you all the best.
Thank you, sir. Thank you. Now I welcome Dr. Puri, sir, to say a few words and start the session.
Very good afternoon to all of you. This is our initiative with postgraduate students, IAP East Delhi in association with IAP Delhi. So that the reach is far and wider. And every Wednesday and the third Wednesday, first and third Wednesday of the month, we are doing this activity. So besides postgraduate students will get a chance to present their this talk, and under the supervision of a senior most consultant who is himself is very experienced and learned in his field. So for this today we have urinary tract infections in children. To present, Dr. Archie is there from Max Patparganj, and Dr. E.S. Vasudev sir, senior nephrologist at Max Patparganj Hospital. So I think we all be benefited from this discussion. STG protocols with some latest inputs have been there over the year. So I think we can start right now. Over to Dr. Lalit. So please start it.
Dr. Archie, please start the session.
Yes,
Right.
And please share the slides.
Yeah, thank you very much. I think it's a very good initiative by IIP Delhi and IIP East Delhi for the students as well as other pediatricians, and this should continue. And today's talk, as already highlighted, is on urinary tract infection, and Dr. Archie is going to present the talk, and then we can have a discussion on the topic. Dr. Archie, please.
yes, sir. Good afternoon to all, sir. Our topic for today is urinary tract infection in children. So first, one second. Yes, sir. So first introduction about the little bit of introduction about the urinary tract infection. Urinary tract infection, it is a very commonly seen infection in young children, especially in infants. It is very common and presents with very non-specific symptoms. So the prevalence of UTI is 2 to 8% in children. Whereas in infants, this is more seen in males, whereas after 1 year of age, it is seen more in females. And why this is important is because UTI usually presents with very non-specific symptoms like fever, irritability, lethargy, refusal to feed, and not presents does not present with the urinary tract symptoms, so it's difficult to diagnose. And also it has very severe complications. So even after one episode of febrile UTI, there is a very high risk of formation of renal scar, which is as high as 20 to 30 percentage. And there's a risk of long-term kidney damage. Also, even after one episode of UTI, there is a recurrence risk, and the recurrence is seen in 10 to 30% of the cases. So now the etiology of UTI. How does UTI happen? So mostly it is caused by the colonic bacteria of the gut only, and the most common organism which is involved is E. coli, which is seen in 60 to 92% of the cases. Other organisms that can be seen are Klebsiella, Proteus, Enterococcus, and Pseudomonas. And rarely we can see organisms like Staphylococcus, Streptococcus, or even fungal infections like Candida. These can also rarely cause UTI in immunocompromised cases, but not normally seen. Mostly the E. coli is mostly involved in causing the UTI. There are some risk factors which increase the predisposition to have a UTI. So if a child is less than 1 year old, if after 1 year of age, it is more commonly seen in females. Any child who is undergoing toilet training has a very high risk of getting UTI, or if there is any voiding dysfunction, any congenital anomaly of the kidney and the urinary tract, or any obstruction is there, these can also increase the risk of having a UTI. Any bowel bladder dysfunction, so any constipation and poor perineal hygiene, or if the parents are using diapers throughout the day, all of this can increase the chances of having UTI. So now I have divided clinical features according to age and according to the site of involvement. So usually if the child is less than 3 months of age, we will see non-specific symptoms more commonly, like fever, vomiting, lethargy, and irritability. And specific symptoms like abdominal pain or jaundice, hematuria, foul-smelling urine, these will be less commonly seen. Whereas in infants who are more than 3 months of age, if they are pre-verbal, we will see more fever as the most common symptom, followed by abdominal pain, loin tenderness, vomiting, poor feeding. And less commonly, we will see symptoms like lethargy, irritability, hematuria, foul-smelling urine, or failure to thrive. Whereas in verbal children, we will now start seeing more specific symptoms like increased frequency of urination, dysuria, or abdominal pain, dysfunctional voiding. And in these patients, less commonly, we will see non-specific symptoms like fever, malaise, and vomiting, etc. We can also see clinical features according to the site of the involvement. So if the upper urinary tract is involved, this usually manifests as fever, abdominal pain, vomiting and diarrhea, malaise, etc. Whereas lower urinary tract involvement will present as dysuria, increased frequency of urination, urgency in urination, suprapubic pain, hesitancy, incontinence, malodorous urine, etc. So now how to make the diagnosis of UTI? A definitive diagnosis of UTI can only be made if there is significant growth of a single bacterial species in the urine culture report. So the significant growth is defined by the type of sample that we collect. So if we have collected the urine sample using suprapubic aspiration, at least 10 to the power 3 colony forming units per ml is considered as significant growth. If the sample has been collected using urethral catheterization, the colony count should be 10 to the power 4 at least, or more than 10 to the power 4 colony forming units per ml. And if the sample has been collected using clean catch method, the 10 to the power 4 to 5 colony forming units per ml is the definition for significant growth. But we usually do not wait for the culture report. We because we have to start antibiotics as soon as possible, so we can make a presumptive diagnosis using our simple bedside test like urine dipstick, or doing urine analysis by microscopy. So we can check for leukocyte esterase and nitrite on the dipstick, And in microscopy, we can check if there is any pyuria. So pyuria is defined by at least 5 or more than 5 WBCs per high power field in a centrifuged sample, or at least 10 or more than 10 WBCs per millimeter cube in an uncentrifuged sample. So the sensitivity and specificity of the simple bedside tests and the microscopy that we are doing to make a presumptive diagnosis is, if we check for leukocyte esterase alone, leukocyte esterase has a sensitivity of 83% and specificity of 78%, whereas nitrite alone has a sensitivity of only 53% but a specificity of 98%. If we combine both of them, leukocyte esterase plus nitrite, this has a higher sensitivity of 93% and specificity of 72%. Similarly, in microscopy, if we check only for the WBC count, the sensitivity is 73%, whereas in specificity is 81. If we check only for bacteria, sensitivity is 81, specificity is 83%. But if we do all of this together, dipstick testing, that is leukocyte esterase and nitrite, and microscopy, this gives a very high sensitivity of 99.8%, which is as good as a confirmatory test. So we can make a presumptive diagnosis on the basis of these rapid tests. And if these are positive, we can start antibiotics as soon as possible. So now how to collect the urine sample, which we will use for urine culture. So ideally in toilet trained children, we want to collect a midstream urine sample, and this can be collected by clean catch method. So before collecting the urine, the perineum should be cleaned with the saline water. And only after that, the midstream urine should be collected, and the first initial part should be discarded. The midstream urine can be collected. But in non-toilet trained children, we can wait for a clean catch method, or we can go ahead and do simple urethral catheterization or a suprapubic aspiration. But we should remember that we should never use a urobag to collect the urine sample, because this can cause increased false positives. And whenever the urine sample has been collected, within 30 minutes of collection, it should be processed to avoid the contamination and incorrect results. So the different types of methods that we can use to collect urine sample in a pre-continent child. Urine bag we should never use because it has a high rate of contamination. Clean catch we can use clean catch method, but it has a high waiting period. We can also use a voiding stimulatory method like a quick feed technique, which involves rubbing the suprapubic area to induce the urination and then collect using the same clean catch method. Or we can use a urethral catheterization or suprapubic aspiration. So it is usually suggested to wait for a clean catch in stable children. If not possible, or clean catch is not giving our urine sample, we can go ahead and do a catheterization or suprapubic aspiration. And if the child is unstable or sick, we should not wait for the clean catch. We can directly go for catheterization or suprapubic aspiration. Now there is something called as asymptomatic bacteriuria and leukocyturia. So bacteriuria, it is defined as the presence of one or more bacteria per oil immersion field in a freshly voided uncentrifuged sample. And but there is no symptoms present. So asymptomatic bacteriuria, there are no pyuria, there is no symptoms, but there is significant bacteriuria in the urine sample. This is commonly seen in girls, and this happens because of the colonization of non-virulent E. coli. So it does not produce any symptoms, and there is no need to treat it also. So no need to give antibiotics in just bacteriuria. Whereas in leukocyturia, this is presence of at least more than 5 WBCs per millimeter cube in a fresh uncentrifuged sample, and more than 10 in a centrifuge sample. And leukocyturia can be seen in multiple conditions like urinary tract infection, any state of systemic inflammation, any fever, or any kidney disease like glomerulonephritis, stones in the kidney, any foreign body. The other investigations that we do in UTI is we can go and do a complete blood count. This can show leukocytosis and neutrophilia. We can do our inflammatory markers like ESR, CRP, procalcitonin. These are increased but usually non-specific. And blood culture is not done routinely, but it can be done if the child is less than 2 months old or if the child is very sick looking. Then imaging that we do in UTI. So ultrasound is our first line of investigation, radiological investigation, and it should be done in all children following a UTI episode. It can also be done in children who have a poor response to treatment or if we are suspecting any obstruction. Second, our second line of choice is micturating cystourethrogram. So this is done if the ultrasound is abnormal or if the child is having recurrent febrile UTI. If there is non-E. coli UTI in less than 2-month-old child, or if we are suspecting a very high grade of vesico-ureteric reflux. So if MCU shows abnormal scan or if the VUR is high grade, if there is recurrent UTI, then we can go ahead and do a DMSA scan, but it is done after 4 to 6 months. And this can detect acute pyelonephritis and it can also identify renal scarring. So what we have learned till now, so how to, all the investigations that we can do. If we are suspecting a child with suspected UTI, we will go ahead and do a urine dipstick test and culture. If the dipstick is positive, we will presume that UTI is there and we will start antibiotics. If dipstick is negative, then we will see whether child has any risk factors. So risk factors like bowel bladder dysfunction or has a previous history of UTI or the child is less than 6 months of age. In these cases also, we will start antibiotic. If then we will wait for the urine culture report. If the urine culture is positive, the UTI is confirmed, we will continue to use antibiotics for 7 to 10 days. In every UTI patient, we will assess for bowel bladder dysfunction and we will do an ultrasound scan. If the ultrasound scan is normal, nothing to be done, we can just watch for recurrence. But if it is abnormal, we will have to do a MCU study. And even after MCU study, if there is high grade VUR present or if the child is having recurrent UTI, then after 4 to 6 months, we can do a late phase DMSA scan. So this is what MCU looks like. This is a normal picture of the micturating cystourethrogram showing the urethra. This is if there is posterior urethral wall present. So we can see the area of obstruction and there is a huge proximal dilatation because of that obstruction. And we can see in this picture, there is anterior urethral stricture. DMSA scan looks something like this. So this is how a normal kidneys look like. And if there is renal scar formation, we can see that the morphological appearance has changed. It is a little bit bumpy and irregular looking, whereas the right side kidney is completely normal. So the imaging that we did is whenever the child has a first episode of UTI, we will assess for bowel bladder dysfunction. We will go ahead and do a USG. If it is abnormal, we will do a micturating cystourethrogram. If on MCU study, if there is VUR of grade 3 to 5, or if the child has recurrent UTI, we will go ahead and do a DMSA scan after 4 to 6 months. Now the treatment for UTI. So antibiotic therapy should be initiated as early as possible and it should be initiated preferably within 48 to 72 hours of the onset of fever. And we usually prefer oral antibiotic over IV antibiotic. But in some cases, we can give IV antibiotic also, like infants which are less than 2 months of age, if the patient is severely ill and if the patient is unable to take orally. So in these cases, we will prefer IV antibiotics. But in studies, we have not seen any difference between oral and IV antibiotics in terms of resolution of fever or reduction of the kidney damage at 6 to 12 months. And the antibiotic that is used is a third generation cephalosporin or co-amoxiclav is used as an initial empirical antibiotic therapy. And this is used for 3 to 7 days for children who are having cystitis and 7 to days who are having acute symptomatic UTI. So these are the doses of the common antimicrobials that we use. So orally we can use cefixime, which is used as 10 mg per kg per day in 2 divided doses. Or we can use amoxicillin or co-amoxiclav as 30 to 50 mg per kg per day in 2 divided doses. Parenterally, we can give ceftriaxone 75 to 100 mg per kg per day, again in 1 to 2 divided doses, or cefotaxime, gentamicin, all this can be given. So what all we saw till now is if a child comes with fever without focus, who is having also for more than 48 hours, and has any specific urinary symptoms, so we will, in this child, we will suspect UTI and perform a urine culture and a dipstick testing. If on dipstick leukocyte esterase or nitrite is positive, we will make a presumptive diagnosis of UTI and start empirical antibiotics. And if the dipstick is negative, we will see whether there are any risk factors present. So risk factors like bowel bladder dysfunction, primary vesico-ureteric reflux, or a history of UTI, or if the child is less than 6 months of age. In these, if any risk factors are present, then we will again go ahead and start empirical antibiotics. If no, we will just wait for the culture report. So if the urine culture comes as positive, we will continue the same antibiotic. If sterile, we will stop the antibiotics and consider other diagnosis. And if it comes positive and we have not started antibiotics till now, we can go ahead and start antibiotics now. So follow up in these cases. So in every episode of UTI, first we want to improve the symptoms. We want for the child to have symptomatic improvement, and fever should be completely resolved, and child should go back to his daily living activities. And we will document a normal urine analysis at the end of treatment of the current UTI episode. But there is no need to repeat any urine culture unless we are suspecting that there is a new urinary tract infection. Then at follow-up, we should periodically monitor their growth at every follow-up visit. Their urine analysis should be done whenever next during further febrile episodes, we should do their urine analysis if there is a known risk factor for UTI. In every 6 to 12 months, we should evaluate their blood pressure. And if a child had a very severe complicated UTI, or the child has recurrent UTIs, then in that child, we should assess the renal function every once a year. And we can also watch for proteinuria after successful treatment of UTI, because this is associated with pyelonephritic renal scarring. Now, what is recurrent UTI? So recurrent UTI is called as 2 episodes of urinary tract infection during any time period in childhood. So does not have to be, and no time period is fixed. Any time period, if there are 2 episodes of urinary tract infection, we will call it a recurrent UTI. So how to prevent recurrent UTI? We have to treat the constipation in the child. We have to give toilet training to the child so that the child can do frequent timed voidings. We have to manage if there is any bowel bladder dysfunction present. And if it is very severe, the child is having multiple recurrent UTIs, then we can also think of antibiotic prophylaxis in such a child. Just a few lines on bowel bladder dysfunction. So bowel bladder dysfunction includes lower urinary tract symptoms along with constipation or encopresis. And why this is important is because there's a very high association between bowel bladder dysfunction and recurrent UTIs and primary VUR. So all of these are linked together. And therefore, all children with recurrent UTI should be screened for bowel bladder dysfunction. And diagnosis is based on, as we saw, it includes lower urinary tract symptoms. So there will be a history of lower urinary tract symptoms like urgency in urination, frequency of urination, hesitancy, and along with that, there will be some bowel history of constipation or encopresis. And in these cases, the management is focused on improving the toilet training. We want the child to have frequent timed voidings. We will increase their fluid intake. We will treat the constipation with laxative and increase their dietary fiber intake. So, final approach to every case that we have seen till now. So if a child comes as an uncomplicated first episode of UTI, child is more than age 3 months old, child is non-toxic and accepting oral feeds, we will do a dipstick testing, we will send for urine culture. We will start, if the dipstick is positive, we will start the child on oral antibiotics. If we are noticing clinical improvement within 48 hours of starting the antibiotic, we will continue the same antibiotic for 7 to 10 days. And urine culture is not repeated if good response is noted. And in all these UTI episodes, we will go ahead and do a ultrasound scan. If ultrasound scan is abnormal, we will have to do, or if the child is having recurrent UTI, we will do a micturating cystourethrogram. If micturating cystourethrogram shows high grade VUR or child is still having recurrent UTI, we will do a DMSA scan after 4 to 6 months. If a child presents as the complicated or atypical case of UTI, that is age is less than 3 months, or the child is having fever of more than 39 degrees Celsius, child is sick looking, lethargic, dehydrated, vomiting, refusal to feed, any renal angle tenderness is there, serum creatinine levels are elevated, or if on culture the UTI is by a non-E. coli organism. In these cases, we will hospitalize the child. We will start the child on IV fluids, give empirical IV antibiotics. And if we are noticing improvement by the same antibiotics, we will continue those for 10 to 14 days. In this case, antibiotics will be given for 10 to 14 days. In this case also, there is no need to repeat urine culture if there is good response. And if there is recurrent UTI, then or if the first UTI was less than 6 months old, and if there is presence of any known risk factor, then in these cases we will have to further evaluate them and do a renal and bladder USG, then MCU and DMSA renal scans. So this is how we approach any patient. So whether it is a first UTI episode or whether it is a recurrent UTI episode, whether it is simple, uncomplicated or complicated, this is a basic management. Thank you.
Thank you, Dr. Archie, for a very nice presentation. I think we can close the slide deck and then we can come on the platform. And if there are any queries, questions, discussions, we can
Yes.
look at the chat box if there are any questions. Right now, I can't see any. So very nice presentation, and you have covered almost all the aspects of urinary tract infection, right from the picking up, diagnosis, treatment, and investigations. A few things which I would like to just highlight, apart from what you have already said.
Yes.
The newer guidelines have been made, recently released in 2024, and earlier we had the last guidelines were in 2011. So a lot of changes have occurred over this period of about 12 years, 13 years or so. And as rightly pointed out, the index of suspicion for UTI has to be very high because the symptoms, as you mentioned, are very non-specific. So sometimes they may not be clear symptoms like dysuria, urgency, frequency, fever, and sometimes it's just a fever without any focus. So my message to my young pediatric friends would be that if you have a child who has got fever and it is just like not a viral fever past 3 days, 4 days, and you can't find a focus, please look for UTI as the cause, underlying cause, and that may be one. Secondly, Archie, you've already highlighted about the urinary enzymes. This is a newer thing which we have added in the guidelines. Urinary enzymes by dipstick is the first thing which we do as a screening test, which is very convenient. It can be done at bedside in the clinic. And if both the enzymes are positive, you can immediately send the urine for microscopy. And if the symptoms are suggestive of UTI, send this urine for culture, and then you can start antibiotic in a presumptive diagnosis till the culture report comes. So that helps as a very quick method for diagnosis. Then Eurobags you've already highlighted. Just wanted to emphasize that collection of urine by Eurobag is just good for physical examination, for seeing the volume, for seeing the routine examination, but never use it for a culture. And sometimes if it has been sent by mistake for culture, then if the report is negative, then it has got a predictive value that you are not dealing with UTI. But if it is positive, please do not give any emphasis to that report and send a fresh culture if you are suspecting UTI, and don't rely on the urine bag collection sample for culture. Then another highlight change which has been brought in the newer guidelines is the culture sensitivity, the colony count, as already highlighted by Archie. For the midstream urine, the colony count has been brought down from 10 raised to the power of 5 to 10 raised to the power of 4, lest we were missing a lot of children with urinary tract infections. So now the colony count is the cutoff for midstream urine is 10 raised to the power of 4, and that's one change. Again, from treatment point of view, you already highlighted that the world over, there's a concern about antimicrobial resistance. And in India also, we are concerned about our younger children having antimicrobial resistance. So the newer guidelines has cut down on the duration of antibiotics. And this again, as highlighted, for lower UTI, 3 to 5 days is good enough. And for upper UTI, 7 to 10 days is good enough. Earlier, we were advocating 5 to 7 days for lower UTI and 10 to 14 days for upper UTI. So now the duration has been cut down, and also we are preferring to start with oral antibiotics unless the child is very sick or having vomiting. Oral antibiotics are good enough even for febrile UTI, for upper UTI. And if you have started on IV antibiotics also or parenteral, you can switch to oral after 2 to 3 days if the child is symptomatically well, and then complete the rest of the course of total duration with the antibiotics, oral antibiotics. Again, during investigations, you already highlighted that ultrasound has to be done in all the children, and we have to be little more selective in picking up children for micturating cystourethrogram, which we were doing more rampantly earlier. So we are being very selective because it gives a high radiation, and it has to be done in a proper fashion under antibiotic cover, and with proper guidance that we do not expose the child to very high radiations. Then again, repeat urine cultures after the treatment of the course should not be done. Sometimes we get trapped, we send for the culture again. There's a colony count, 10 raised to the power of say 2 or 3, and then 10,000 colony count. And again, we are trapped. And then parents would ask if the urine is still not sterile. Should we give more antibiotics, which actually are not required? So best is not to send the repeat culture unless the child is sick or not responding. And at the end of the treatment, if the child is good, better, symptomatically, just leave the child alone. Then about the recurrent UTI, of course, for the VUR, we were advocating antibiotics in all the children from grade 1 to grade 5 for long term till 5 years of age earlier. But now we are restricting the use of prophylactic antibiotics after treatment only to the high grade VUR, grade 4 or 5, and sometimes grade 3. But grade 1 and 2, most of the times do not require antibiotic prophylaxis for long time. And even who have been started on prophylaxis in higher grade, the prophylaxis can be stopped earlier now if the child has already crossed 2 years of age, does not have bowel bladder dysfunction, no constipation, has not had any UTI in last 1 year, we can stop prophylaxis earlier also. So that's another change which the guidelines have highlighted. And again, for the prophylaxis, we are using a very narrow spectrum antibiotics, which would be required in bowel bladder dysfunction and high grade VUR, and don't use broad spectrum antibiotics so that the child does not get resistance. And you have already, Archie, highlighted about the recurrent UTI. Now again, cleaning the perineal area and maintaining a very good hygiene and avoiding constipation is very important. So all my young friends should teach mothers how to clean the perineal area. It's a front to back cleaning. And if you just tell them that you have to avoid the contamination of the urinary area by the fecal matter or the water trickling from the fecal area, the mothers will be able to understand. And at times they are using wipes, which I have seen are being used in a very erroneous method, that they are using only one wipe and multiple times they are cleaning the area with one wipe, which is not good. So either wash it properly and front to back washing, and a good hygiene is to be maintained. And you have already highlighted about prolonged use of diapers, which has become like a fashion with or a necessity sometimes with working parents, and they put them for long hours, not only day but also night time. So I think if there are any questions, queries, we can take up. And very nice presentation. So congratulations to the IIP Delhi and IIP East Delhi and all the stalwarts, office bearers, so for organizing such a nice subject, introducing a nice subject which is of great importance in clinical practice. And Archie, very nice presentation. Congratulations again. Thank you.
Thanks,
And
sir.
over to the organizers. Dr. Ajay is there, Dr. Lalit, Dr. Puneet, they are all here. So over to the organizers.
Very well presented, Dr. Archie. And sir has almost summed up whatever you said, and with practical points he has told. There are few questions in the chat box. There one is if a child is responding to one is in case of recurrent UTI, if ultrasound is normal, should we still go ahead with MCU or wait?
See, I would
Sir.
say if it is a true recurrent UTI and you are very sure that the cultures have been done properly and the child has got febrile UTI and has been lacking on weight gain and other problems are there, and if the child's ultrasound is normal, these are the children who would cautiously merit further investigation in form of MCU, and then if there's a reflux, then DMSA scan. But be cautious that recurrent UTI, sometimes the problem is that these children come with after having taken multiple courses of antibiotics, and we are never sure whether they were actually true UTI or some other cause of fever. So if you are sure that the cause of fever and all these symptoms was UTI and is under your supervision and it's a multiple times, then we need to do all the three investigations: ultrasound, MCO, and DMSA.
Okay, so the child has to be symptomatic and not improving that way. Other is the child is responding after empirical antibiotic. Culture shows resistance to empirical antibiotic. What shall we do? I think this question has been answered. If child is responding well, nothing to be done. Am I
Yeah,
right, sir?
very right. And I think we are treating the patient and not the reports. And again, we tell them, tell all our friends that uh, if the culture report, there's a difference between in vivo and in vitro sensitivity. So sometimes the child may be responding clinically and the culture report may not be showing sensitivity, but go by the clinical response, do not change the antibiotic. That would be the right thing.
So another query, Dr. Bhatt is asking, cefixime is preferred for first line therapy or amoxiclav as
Both are
empirical
equally
therapy?
good. Both are equally good, and I use lot of amoxiclav because they are simpler to take and taste-wise also good, and they have very good efficacy, very good concentration in the urinary tract. So amoxiclav is equally good, and you can use it without any hesitation.
What about cephalexin and cefadroxil? That can also be used?
That can be used. Normally, we reserve them as prophylactic, as for antibiotic for if you have to give it on continuous basis. But otherwise, first generation also works. But if the child is sick, having fever and having symptoms, and you are treating an upper UTI, cefixime or co-tri would be, coamoxiclav would be better. But if it's a lower UTI, just lower symptoms, then first generation cephalosporins also can be used safely and effectively.
If the child is symptomatic, like burning urine micturition is there, then is there any role of Alkazol probiotic in UTI?
No, no role of alcohol. I think it's just that it gives a little symptomatic relief temporary for a day or so. But if you give plenty of fluids, that would also act as good as giving any alkalizer. And normally we say that earlier we had antibiotics where the pH of urine needed to be changed. But now with these potent antibiotics, we don't need to change the pH of the urine, and just antibiotic alone with plenty of fluids is good enough. And second thing you said about the probiotics, I think there are
Yes,
no
sir.
concrete studies about the use of probiotic, though sometimes I've seen gynecologists have used probiotics in elderly ladies where there's recurrent UTI, and they claim, but in children, we don't have any studies where probiotics have shown any improvement, and any recommendation is not yet on the cards.
What about cranberry juice? They say some
Cranberry
benefit.
juice, yes, cranberry juice can be used, but not for treatment. It's usually for preventing UTI. After the UTI has cleared, then it can be used for 2 to 3 weeks. But the dose has to be accurate. And most of the time, what you get is the cranberry drinks where they are not, they are juices, they are not actually concentrates. And they have a very small concentration of cranberry in it. So if you have to use a proper preparation where there is a good concentration of cranberry and not the drinks or the other commercial preparations.
And what about D-mannose? D-mannose also somewhere they mention that sometimes it is also useful.
Not, I mean, in our literature, we have not mentioned anything about it. And there are so many things which people are using. Even there were some couple of studies somebody had done on probiotics, but no systematic trials and no controlled studies have been done on these things.
Okay, sir. There is a one thing, I think the role of phosphomycin monotherapy for UTI in children. I think that will depend on the culture sensitivity and
Yes,
in recovery.
occasionally we have used phosphomycin, not very routine, but sometimes the sensitivity pattern is such and the child is very sick and sometimes hospitalized, and we can give under controlled conditions phosphomycin has been, but in older children I've used it over 10 years of age. In younger children, it's little tricky, and you have to be very cautious in using this drug where it is still not in our armamentarium in the literature.
Sir, what's your take on if the baby this antenatal hydronephrosis, should we use
I
antibiotics as
think, yeah, I
prophylaxis
think it's a very
at
nice
times?
question, very good question. See, earlier we were using prophylactic antibiotic in all children who showed hydronephrosis from day one. But with time, we have learned that all children do not need antibiotic prophylaxis. Unless the child develops UTI, we don't give antibiotic prophylaxis. Secondly, if the child has got a very high grade of pelvic junction obstruction and the pelvic system is greatly dilated, and we are investigating the child for further investigation for a short period. In the next couple of weeks, 2, 3, 4 weeks, we can put this child on antibiotic. But in other children where the pelvic calcium system is not greatly dilated, we would restrict antibiotics and give only if the child develops UTI.
Mhm. Other indication could be if the mother has got any, mother is symptomatic, or mother has got some fever or UTI or something like that.
No, I think mother's fever and UTI should not be transferred to the child. And if it is the child has UTI, only then the child should merit antibiotics. Because putting the young baby's few days old child on antibiotics, unless we are justified, I think we should avoid them if it's not a very pressing situation.
Sir, there is a often we get reports, radiological reports are there where they mention cystitis. So, what about cystitis?
Cystitis,
Should we
I think
treat?
cystitis is a misnomer by radiologists. Cystitis is a clinical diagnosis. It's not a radiological diagnosis. And cystitis means the symptoms are pertaining to the lower urinary tract in form of dysuria, increased frequency, lower pain abdomen. And sometimes these are the symptoms for lower urinary tract, which we call as cystitis. So, but sometimes the bladder may show some echogenic features in ultrasound, or the bladder wall is little thickened, and the radiologist will label it as cystitis, but that is not a radiological diagnosis, and this is a misnomer. So don't look at that diagnosis if radiologist says, unless you have symptoms pertaining to lower urinary tract.
So one more question: can we use flexovate in older children if they are experiencing this pain and spasm kind of a situation?
Yeah, it can be sometimes used. I have used them, and occasionally in older children, and only for symptomatic treatment for a couple of days if they have very severe dysuria and they are experiencing lower abdominal pain. Then we are using sometimes, but not as a routine for very young children. And
Okay,
another
sir.
thing very important, that when the sonologist writes thickness of the bladder, I think he should be very clear whether he's measuring the thickness in the full bladder or empty bladder, because there would definitely be variation. If you are taking in an empty bladder, the bladder wall will look much thicker. If the bladder is distended and full, the wall will look thinner. So if he writes about thickness, please, when I write for an ultrasound, I say ultrasound KUB area with all measurements, including kidney size, pelvic size, and bladder size, post-void residue, and bladder wall thickness. We have to specify on a full bladder. So otherwise, these can be misleading measurements.
At times they also mention this ecogenic, floating ecogenic foci.
Yeah, sometimes we see that
Shadows.
if there are WBCs or if there's some blood in the urine, there can be floating echoes, which not necessarily means a UTI, but you should rely on your routine examination, enzymes, and microscopic examination and culture for diagnosing UTI, and not only the presence of floating echoes should label it as a UTI. Even if the urine is very thick, morning sample, concentrated urine, sometimes it may show these floating echoes. If there are some tints of RBCs, it may show. There's a
There is
question,
a
when to perform
yes.
MCU scan during treatment or post-treatment? Normally, if there's no urgency in that and complete the treatment, I would normally complete the treatment, let the child be comfortable and not having fever, and then plan an MCU, and that also under antibiotic cover. And it should be done by an expert. Like all MCUs, I mean, first 20 years I had been doing all of them myself, catheterizing myself, so that there is no trauma, no infection being introduced. And now our team is doing it. And it's always one of our doctors who catheterizes the child, not the radiographer. And it's always done with proper aseptic precautions under antibiotic cover. So MCU is a little invasive test, and it should be done very meticulously by an expert. And once we are taking pictures also, we have to be very giving a controlled radiation and take only number of pictures as are required, not just continuing to take pictures.
I think there is one more question. Can recurrent lower UTI cause renal scarring? I think
Usually not. Usually not. It's the upper UTI or the pyelonephritis, and which is febrile pyelonephritis that can cause scars. But cystitis or lower UTI would, once the infection doesn't reach the kidney, there is no reason to have scars in the kidneys.
I think that's why they have written recurrent lower UTI.
Like recurrent lower UTI, again, I would say more related to hygiene problem, and constipation is one thing which I remember when we were students, constipation was hardly a problem and we hardly treated it. But now it has become one of the most common symptoms or the disease in gastroenterology. And one of my gastroenterologist friend was telling me that out of 5 major diseases in gastroenterology, constipation is one of them. So constipation is a very major underlying problem which should be looked into apart from the hygiene issues in these babies for recurrent UTI.
So I think, are there any more questions if someone wants to ask?
Yes, sir. Sir, am I
Dr.
allowed?
Shalu, welcome, Dr. Shalu. Yes, please.
Thank you, sir. Thank you. And sir, am I audible?
Yes, yes,
Ah,
yes.
yes. Please go
Right,
ahead.
sir. So, likely, I would like to congratulate on a very excellent presentation by Dr. Archie under excellent moderation by Dr. Vasudev, sir. And Dr. Vasudev, sir, congratulations for the launch of the book.
Oh, thank
Uh,
you. Thank you. This is the new
yeah,
IIP Pediatric Nephrology book, and this is launched under the IIP and recently in
in
Calcutta.
the Pedicon, sir.
And this Pedicon, and this is available, and this has got 30 chapters on almost all the diseases covered in kidney diseases by experts from all over the country. So this is
Right.
an excellent book, and you can purchase it. I can send the link on the on your groups later. By the JP, it is being not very expensive, and we are all doing pro bono work. So you can, whatever the earning is, all goes to IIP.
Great work, sir. Great work.
Thank
Great
you.
work.
Sir, yeah. So a few queries, sir. Like it is always said whenever it's said that we should always send the early morning urinary sample. Uh, does it have any evidence to say, sir, that we should only send early morning samples, or any sample which is sent clearly and with utmost care should be taken?
Early morning sample is mostly a concentrated sample, and it has got a high concentration of all the element. But otherwise, if you cannot catch it and if the child has not passed urine for next 2 to 3 hours and the sample is concentrated, you can send that sample, because in a dilute sample, even if the colony count comes, it would sometimes be a lower colony count, which may confuse us whether it's true UTI or not, and then we are debating whether to start antibiotics. So dilute urine is one of the causes of a low colony count, and concentrated urine is better, whether it's in a daytime or early morning, that would not matter.
But how do we ensure the urine is concentrated in a small child, sir?
Small, if the child has not passed urine for next 2 to 3 hours, then we can collect it. But in a small baby, when the child is passing every hour, then we cannot wait for 2 hours. He will not pass on command. If the child is up and about and understands verbal commands and can hold urine, then we can hold the urine. Otherwise, that's why early morning sample means it would be mostly a concentrated urine, and that would pick up the all the elements, whether they are WBCs, RBCs, or bacteria, they are in better concentration. But sometimes it's not possible. The child has come to the clinic and you want a culture. So you can ask them if the child can hold for as long as possible and then send a culture with all the proper precautions as already mentioned.
Right, sir. Sir, we often, when we send samples, we often say that budding yeast cells seen.
Budding yeast cells normally do not have any significance, and they are because this sample keeps lying for hours and hours in the lab, and you know that these yeast cells can appear, but budding yeast cells does not mean it's a fungal infection.
So we should ignore it, sir. Or do we need to treat it, even if the child is symptomatic?
Symptomatic, but then unless you have a proper, you can, if you are doubtful, then you can send a fresh urine sample and ask the pathologist to have a look under the microscope if there's any fungal hyphae, and if possible, you can send a culture, but just don't treat as fungal infection based on the presence of these, um, I mean, just a flimsy thing we should not diagnose as fungal infection.
So do these guidelines really change in a child who is catheterized versus non-catheterized?
Catheterized, I mean, for long term, like
Yeah,
over
maybe,
in the
sir. There is
hospital.
a child.
ICU setting.
ICU setting, I think if the child is already catheterized, best is that I would normally not try to remove the catheter, but try to disconnect the catheter from the tubing and not collect from the bag. Directly take from the catheter, clean the catheter with plain water, don't use antiseptics there, and collect it directly into the culture bottle from the catheter after disconnecting the tubing. So that can be collected, and culture can be sent from there rather than removing the catheter and then reintroducing it.
So some I have seen somewhere practicing that they use a sterile needle and a syringe. They clean the catheter and they puncture it and they collect a sample through it. So is it advisable to do that, sir?
Well, instead of that, if we can disconnect the catheter and clean the tip with plain water and then let the urine flow freely and collect in the culture bottle directly, that would be good enough. Why do we need to, I mean, puncture and then um, use a needle and clean it? I would normally I do it like that to disconnect the catheter from the tubing and clean it with plain water with aseptic precautions, and then let some of the urine flow and then take the culture in the bottle directly.
Right, right. So any take on use of nitrofurantoin as a treatment in culture negative UTIs?
No, nitrofurantoin is a very good drug, but it is very good drug for prophylaxis, not for the treatment because it doesn't have a very good tissue concentration. And we should not use NFT for the treatment of UTI, though sometimes gynecologists I have seen even for elderly ladies, they give as treatment also, which can be sometimes effective. It's a lower urinary tract, normally the cystitis or lower urinary tract infection. But in children, we don't use it for treating UTI. For prophylaxis, use a very small dose of 1 to 2 mg per kg, and that also at bedtime dose. But the problem is it sometimes causes nausea, and being even a good drug, it is not tolerated by children. So I normally sweeten it with something and then give it to the child in a small dose of 1 mg per kg. If the child can tolerate, I haven't hardly seen any resistance to NFT. It's a very good drug for prophylaxis, and it's a narrow spectrum, does not alter the gut bowel bacteria. So it can be used, only the problem is tolerance.
Right. So any difference in, sir, management if a child has an underlying renal stones?
For UTI?
Yes, sir.
Oh, of course, the
The child like
chances of UTI will increase if the child has stones because the bacteria are finding a good haven to have concentrate and culture and grow. So apart from treating UTI, I would also try to figure out what is the cause for these stones in a small child, whether it's something to do with the familial stone formation, with the environment, with the diet, and investigate. And if the stone is large enough, then we sometimes need extra ESWL and for breaking the stone, or sometimes we have to put in a cystoscope and catheter basket it out if it is sticking at a VUJ junction. And if it's higher up, then we of course can break it in kidney or in ureter. And if it's a bigger stone, it may normally not pass the VUJ junction. So we have to basket it out. If it comes down to the bladder, a small tiny stone of 4 5 millimeter, it's likely to pass on its own. But then we have to find out, stone analysis should be done to find out what is the type of stone, what precautions we have to take so that there's no recurrence, and only treat UTI if there is a presence of true UTI. Prophylaxis, I will not give prophylaxis in these children because stones may stay for months. So we don't need to give prophylaxis again and again for these children. Just treat UTI if it is present.
right. Thank you, sir. Thank you very much, sir.
Thank you.
Right.
There is a, like we often find, sir, there is a one more question in the chat box. If the culture is showing all the resistance or all the resistance with all the antibiotics.
Yeah,
So
occasionally we get
from
such
the
reports, but I take those reports with a pinch of salt unless the child is really sick and has got recurrent UTI. Most of the time, it's the faulty collection which causes, and these bacteria are mostly the gut bacteria rather than bacteria from the urinary tract, and they would have resistance to almost everything. So in that case, I would ask the mother to repeat the culture with proper precautions after cleaning the perineal area properly, and then taking a midstream. If we are not sure, then I would put in a catheter and take the sample and then see. But most of the times I've seen these reports are fallacious, and the culture has been not taken properly unless the child is really sick and having recurrent UTI. And in that case, again, we have to choose an antibiotic if it's required, which is the most common sensitivity pattern in your area. And otherwise, we can repeat the culture if you are in doubt.
okay. And there is one more query. If we have to start the prophylaxis, then how long? I think depends on the condition. So you can answer, sir.
Yeah, if it is a VUR, a grade 4-5 VUR, then we require it for 2 years. And during this period, again, after 2 years, if the child has not had any UTI for last 1 year, we can stop the prophylaxis. Or if the child is over 2 years of age and has had no bowel bladder problems now and is not constipated and there has been no infection, then again we can stop after 2 years of age. And otherwise, in bowel bladder dysfunction, we continue till the bowel bladder dysfunction is resolved, because these children would have constipation, other problems, urinary symptoms, and they would require antibiotic prophylaxis for longer periods till we are rid of bowel bladder dysfunction.
I think there are no more queries. We can stop sharing. Uh, Dr. Lalit,
Yes, sir.
are you there?
Yes, sir. Yes, sir.
Oh, there's another
Yeah.
question by someone: is urine sterile always? See, urinary tract is a sterile area, unlike the gut where the bacteria commensals are present. Urinary tract is a sterile area, and in normal course, we should not have any bacteria in the urinary tract unless it is contaminated and there's infection.
Thank you,
Thank
sir.
you. Thank you very much.
Thank you, sir.
It
Thank you
was
for
such a
sharing your experience, vast experience, and no one other can summarize urinary infection like this, like you. And thank you, sir. And thanks, Dr. Archie, for this wonderful slides and wonderful presentation. And thanks, IAP Delhi, for providing us this platform. I hope we'll continue with these sessions every Wednesday, every alternate Wednesday.
Yes,
Thank
I
you.
think it was a pleasure being with all of you, and it's a wonderful initiative, and we should continue these sort of teaching exercises. And we also learn a lot from sometimes youngsters. They are very well read, and they can also sometimes tell us about the newer developments and researches. Thank you very much. Thank you.
one thing that I want to just announce. We are having a president action module on 15th of this month, February. So this is pneumonia under 5 year old children. So this will be held at Wood Apple Residency. Afternoon, this is Sunday. In the afternoon, most likely from 2 p.m. to 6 p.m. or so. So I think we will give the flyer and the advertisement in every group. So I request all of you to please enroll for this and make it a very good this thing event. So with that, I think we can close. Thank you, sir. Thank you very
Right.
much. Thank
Thank
you,
you.
Dr. Archie, all
Okay.
the attendees
Right.
for a
Thank you.
very wonderful and nice presentation and moderation, sir.